welcome back to the Advancing Healthcare Innovation Show. I'm your host, Michael Stamatinos. And if you're new to us, we're super excited to have you here because you know what? We're bringing some very exciting conversations with leaders that are painstakingly shaping the future of healthcare. And we happen to be really passionate around healthcare innovation, adoption, access, and leadership. And just by way of it, it's your first time tuning in. Let me just sort of back a couple steps back and just tell you a little bit about what we're trying to do here. So we're a healthcare innovation company. We're focused on bringing stories of innovation within healthcare to life. And the aim is really highlighting people that are in the trenches, truly innovating within our space and giving them the platform to share their stories with the world. And we've got just an amazing, incredibly action-packed year with new content, some amazing interviews that are being planned. And if you haven't done before, make sure you hit the subscribe button now so that you can get any new material that comes out to you right directly to you. So as part of our commitment to just kind of keeping you updated with the latest advancements and solutions, we've got just an incredible innovative leader with us today that's pushing the boundaries and really shaking things up. And I'm pleased to announce and introduce Dr. Ali Khan, who's the Chief Medical Officer of Value-Based Care Strategy at Oak Street Health, where he leverages his vast experience to revolutionize healthcare delivery and achieve what we all strive for, the quadruple aim. And his passion is really ignited by the intersection of medicine, entrepreneurship, health policy, population health, and public service. And he expertly really navigates these seemingly complex things and brings them into a way where we've brought about some very impactful transformations. And in addition to his established healthcare career, Dr. Khan is recognized as a national speaker, a strategy consultant to the Institute for Healthcare Improvement, and a mentor to several folks. And as we start today's discussion about healthcare innovation, we're just sort of excited to learn about Dr. Khan's extensive experience and passion for healthcare transformation. So thrilled to have you with us today, Dr. Khan. Welcome to the show.
Michael, thanks so much. Super excited. I think, this podcast is obviously has a fantastic reputation, and just being able to dig in on conversations on, to your point, like what's the work like in the trenches, right? How do we take these concepts of, care delivery, innovation, transformation, pick your noun, right? And actually make it real has been a huge part of the journey I've been really privileged to be on over the past, 10 plus years. And so getting into dig in that way is just always a fun opportunity.
Yeah, I think there's a lot of clamor around healthcare innovation, and we often talk about the sexy side of innovation. But what most don't really look at when you're innovating is that it's really hard, and there's a lot of challenges and there's a lot of learnings. Maybe you can kind of take a step back and sort of share with the group sort of what you're doing now in terms of maybe some of the things that led up to what you're doing now, and what are the things that you're really focused on kind of going into this year, and what are your key areas of interest?
All right, that's a nice small question. All right, so I'd say, listen, I'm a practicing internal medicine physician. I practice primary care in Chicago's West Side, and I've been really lucky to sort of spend pretty much the entirety of my career in thinking about the strategic development, the building, the operational delivery and execution, and then the ongoing iteration of transformative care models for underserved populations, particularly highly vulnerable or structurally marginalized populations, such as like low-income seniors and other folks. So from a clinical perspective, from a population health perspective, from just a day-to-day perspective, like thinking through that work of providing, really superb care that shifts the locus of primary care from reactive to proactive for populations that really deserve that most, and using non-fee-for-service alternative payment models to get that work done as the floor of what's possible has really been the bulk of my work over the past 10 years plus, right? Since coming out of training. Today I serve as Chief Medical Officer of Value-Based Care Strategy at Oak Street Health, which is a national network of primary care centers focused on the needs of vulnerable, often structurally marginalized Medicare enrollees, seniors, and folks who are dually eligible for Medicare and Medicaid. We take care of almost 250,000 patients across 25 states and 204 centers. So you can imagine, we're in places obviously like here in Chicago, our hometown,
Yeah.
but obviously places like Jackson, Mississippi, Albuquerque, New Mexico, Knoxville, Tennessee, right? Little Rock, Arkansas, Longview, Texas, or Providence, Providence, Rhode Island, or Washington Heights in New York City. So a lot of different places, right? By and large, that have similar themes when it comes to populations who really need phenomenal primary care and primary care that crosses the T's and dotted the I's to deliver the kind of care that we'd all want, right, for our parents and grandparents. But that doesn't often happen, particularly in primary care and pharmacy deserts that occur, that happen to center around places where there's just a high level of social vulnerability. And so my work as chief medical officer at Oak Street obviously runs around the ongoing iteration and development of our care model, how we execute that across the country, and a lot of the work that we do, particularly in and around how that relates to how we interact with health plans and other payers, how we interact with the federal government as one of the nation's ACO REACH entities, taking care of folks in traditional Medicare, and in addition to folks obviously who are in Medicare Advantage or dually eligible plans. A lot of work on workforce, right, and thinking through how do we know that we have a primary care shortage in this country, and that's for a lot of different reasons. So how do we think through the kind of solutions for all those reasons? And then now, as this year in 2023, we became part of CVS Health in the large enterprise, and how do we work in creating synergies and opportunities to improve care for folks while working with partners across CVS, right? So I spent a lot of time in that work, but that's a continuation of sort of the work of kind of building new systems that I've just had a real privilege to do. First, starting off in the early days as a doc taking care of super sick casino workers on the Strip at Iora Health's first clinic, serving the Culinary Fund, the Casino Workers Union, and through a community health worker driven model that was the highest functioning healthcare team I've ever seen in my life. And so a phenomenal time with Rashika Fernando-Pule and that team, and Andrew Schutzbank and others. And then a number of years on the integrated payer provider side at CareMore Health under Sachin Jain and Vivek Garg and others, really showing what a health plan can do in a virtuous way when all different health plan functions come together, partnering with community physicians, building out our own clinical delivery apparatus, building a safety net for folks for whom, there wasn't always a lot of food security, or there wasn't always a lot of housing security. There wasn't or they were living day to day, working class to make ends meet, immigrant communities of color, so on and so forth. And how to build a network that's supportive and keeps them out of trouble and keeps them happy home and out of the hospital through a mix of both clinical and health plan, innovations was some of the most fun 4 years of my life, but a ton of different learnings that we then been able to bring to Oak Street over the past 4+ years. So in a nutshell, I spent a lot of time both in as I was describing to somebody earlier today, at the diagonal, right? The work of the operations that makes this kind of work happen across, such a large swath of the country, but then also the strategic work and the partnership work that enables us to continue to iterate, develop, and advance this kind of care model to make sure we ensure that just no one's falling through the cracks.
That's right. It just seems as though you've had so many interesting and important tours of duty, stops that really shape you into the leader that you are today. And kind of talking about leadership, when you think about some of the things that you've done, it appears that you're sort of a really strong advocate. I want to bring up a post that you wrote on LinkedIn that I thought was fascinating, and I want to kind of get maybe some more context around it. And I'll quote you. It said, "I love being an internal medicine physician. I love solving mysteries of all kinds, hand in hand with patients and families. I love nerdy physical diagnosis tricks and lab analyses. I love the complex interplay of systems thinking that exemplifies the best of what we do. I love sharing with others every day what it looks like and feels like to practice primary care that doesn't suck. I'm proud to be a general internist for the structurally marginalized at Oak Street Health." I get the sense that And I want to get your reaction to this. I get the sense that you're making it a statement around why we need to have more primary care doctors. Is that off base? Because I feel like you're doing a good job to sort of sell why maybe people need to get into this field. But I'd love to maybe get your take on it.
Yeah, no, I mean, first off, super kind to bring that up. I think like the reason I went into this work, the reason like very much feels like a calling, right? In the context
Yeah.
of thinking about how to ensure that the people who need superb care most get the kind of care they deserve, and what are the levers that are needed to actually make that happen, right? Foundationally, fee for service care delivery has enabled some of the greatest medical innovations that the world has ever seen, right?
Mm-hmm.
But tends to miss the mark when it comes to the work of keeping people healthy, right? 15-minute visits, the resource-based relative value scale, and our views as a outgrow of that system, and all these things kind of come together where we just don't invest in primary care that makes people feel good, whether physically, emotionally, experientially, right?
Yeah.
And it's not a place that sets people up to succeed, right? There's economic disincentives for going into those careers, for many, for nurse practitioners and physicians and PAs and all those sorts of folks.
Mm-hmm.
There's sociocultural disincentives, right? Whether people say things like, "Oh, you're too smart for primary care, you're too smart for family medicine," or so, those sorts of things. But and then there's the experiential disincentives, right? Where we see so much of the national crisis in clinician burnout and
Mm-hmm.
the treadmill sort of feeling that so many people feel that's causing them to leave care delivery or not enter it in the
Yeah.
first place, centered
Right.
in and around just how fragmented and challenging primary care practice, that life is for people, right?
Mm-hmm.
So as I think about what does it take to overcome that from a top of funnel perspective, middle of funnel perspective, bottom of the funnel perspective, right?
Mm-hmm.
Like we see a lot of people focusing on the bottom of the funnel, on like wellness, right? What are things
Yeah.
that we can do for burnout? How do we keep people from leaving? But and if we do those things well, it also starts to create, whether that's financial work, whether that's programs, whether it's more support, minimizing work outside of work, so on and so forth. That's one piece, of course, of like trying to stabilize an existing workforce. But we have a lot of work to do to both then correct the maldistribution of people who aren't necessarily going into these fields to begin with, right?
Mm-hmm.
To come in and practice community primary care or academic primary care or Kaiser primary care, any of those things.
Yeah.
Um,
Yeah.
and then to also correct the maldistribution of like the fact that we don't have a lot of folks who are eager to practice primary care in Gary, Indiana, right? Or
That's
eager
right.
to practice primary care in Memphis, or eager to practice primary care in the Bronx, or eager to practice primary care in, Phoenix, Arizona. And
Mm-hmm.
so like all those things create a ton of different market distortions. But the work we have to do then is to show across the continuum, like top of funnel, how do we expose folks and like medical students and nursing students and pharmacy students and so on to a world in which people are staying in primary care careers for 10, 15, 20 years, right?
Mm-hmm.
Are exposing them to a world where somebody is working, where they see their teachers working in systems that are well supported by big primary care teams and working through social risk and biomedical risk and mental health risk and all this stuff together and actually achieving something, right? Getting off of a treadmill and actually driving real impact.
Yeah.
Like how do we show that those careers are sustainable and financially rewarding, and that they enable the kind of professional development and growth for everyone, be it a medical assistant or be it a physician or be it a nurse practitioner or be it a chaplain or a driver, that
Yeah.
makes people want to stay within that organization and stay in the cause, right? So like I don't mean to make this sort of bigger than it should be, but the implications are enormous, right? For us to actually get
Yes.
the workforce, the health care that we all deserve, the health that we all deserve, we've got to address each of those disincentives, groupings of disincentives in sequence and in parallel, right? And so
Yes.
in that way, like so much of this work today, you know, starts at the focus of the bottom of the funnel. And I think we think about it from an Oak Street perspective of like, how are we building our system with an eye towards the middle of the funnel and the top of the funnel so that we are, constantly iterating to make sure we are making the bottom of the funnel experience really, really sound for our clinicians and our care teams and everyone who works at Oak Street. But how does that reinforce then what we do in the context of growing our own workforces, partnering with people around the country, and exposing folks, whether they come to work at Oak Street or whether they don't, to primary care that's attractive and sustainable and meaningful, and then that they want to do that work in the communities that often motivate them to enter medicine in the first place, right? So all that comes together. It's like, you're right. I mean, like I come from a really deep background of health advocacy and sort of organized medicine, because it is this kind of work that is the actual last mile moving the needle of
Right.
not only just identifying disparities or identifying this kind of maldistribution, but then actually working to fix it, right? And I
That's
think
right.
I like being a fix it guy.
Well, you're certainly doing a lot of heavy lifting. What I found is that the innovators that are doing well and are performing best also happen to be the best executors. But with an organization that's as large as Oak Street and the footprint that you have, it also sounds like getting alignment amongst clinicians is paramount. How are you doing that? I mean, just with all the markets that y'all serve, how with a couple minutes if you can. I mean,
Yeah,
tell us more about that.
I think we spend a lot of time. The core of what we do is centered on how we support a care team and that team to work really robustly together, right? About with in order to serve a, a, a panel of patients. And so for us, part of that work is that when we is in time. And so we see patients in a proactive way on average 8 to 9 times a year for 40 or 60 minutes at a time, right?
Mm,
With not when you think about Medicare's average is 1.3 times a year for
yeah,
17 minutes, right?
yeah, that's right.
And so like time of just like building and establishing relationships, seeing people frequently. Our sickest folks, who we call VIPs, we see, every 2 to 3 weeks, sometimes on upwards 26 times, 27 times a year, right? And that's
Right.
just in face-to-face or virtual like physician or other clinician visits. That's not counting visits with our behavioral health clinicians or visits with our community health workers or touch points with our community engagement teams or any of the other pieces like phone calls and the like that fit into how we make sure that people see us as the first people to call, right? That we're really centering on trust.
Mm,
Part of that, and when you're doing that kind of work, that requires big teams. It requires a lot of resources, and resources becomes a second piece of this, right? Like we take the average primary care panel down from 2,000 plus as it is in most American primary care down to 400 to 500, because
mm,
when you shift the locus from reactive of just seeing whoever walks in the door and hoping that they follow through on whatever you ask them to do, to hey, we make sure people follow up on these things, right? We check in with
that's
them,
right.
we build shared accountability, we help them cross the T's and dot the I's, we help them advance agency. That becomes really critical, right? And so in that way, the work of shifting from reactive to proactive means that we bring big teams together. And so physicians, nurse practitioners, RNs, medical assistants, scribes, sure, as population health specialists, but also, behavioralists and social workers and community health workers and drivers and patient relations managers will help them identify which benefits are available and community engagement
Hmm.
specialists. And then our national teams in population health and clinical operations and learning and you know, care delivery and community outreach and all sorts of other features, managed care services and the like, that are constantly saying, how are we making this complex art as replicable of a consistent science, where we're reducing work after work, where we're reducing the amount that people have to worry alone or worry that things are falling through the cracks? And how do we make that replicable over time, over multiple geographies, so that it's not solely just a, you know, like happenstance or individual heroism that gets people to go forward, right? Because, and we do that through a system, especially our IT systems and our population health platform Canopy, but across all the work that we do in a very Midwestern way. Midwestern engineering, I think, is our big difference. Just heads down work of getting to follow through, right?
Yeah.
So for us,
Yeah.
like making sure that we actually let like people know in a system where they're used to falling through the cracks that, oh, my Oak Street clinical team actually followed up as they said they were going to do with those nutrition instructions. And then they helped me use my EBT or SNAP benefits on Instacart to get meals delivered to my house, which is great because I don't have time to go to the grocery store because I'm helping to raise my grandkids, right? Like stuff like that. Or they identified that like I'm eligible for access to like, you know, discounted electricity or help with broadband access, because a lot of people live in communities that don't have great Wi-Fi or Wi-Fi capabilities, even if they're tech savvy, because of, you know, broadband inequity. And like we connect people to those things. So that crossing the dots, that's like crossing the T's, dotting the I's, that's the work of follow through that actually gets to the what we want, right? So time, resources, and follow through really get to trust. And so we, you know, we have a large national team, team across the country. We've got an enormous clinical and operational leadership apparatus that from the national level down to the regions, down to the centers, right? For a clinical group of, you know, soon to be 800 plus clinicians, with population health directors and outreach leaders and practice managers and all these folks who we are a human capital innovation towards getting this kind of follow through. And the beauty of it is that when we're able to do this because when we take full risk on almost every patient that we take care of, then as we keep people out of the hospital, as we, you know, in the first year we see them a ton, we increase how much they're spending on pharmacy on drugs because they're actually taking them, right, and filling them. You know, we get them to the referrals that they haven't gotten to in a long time, so we increase spend there. But over time, we're able to work with folks, get their chronic disease and mental health issues and social risk factors under control. And then that money that we're saving that otherwise they would have been highly likely to go to the ER, go to hospitals, or so on and so forth, we're able to reinvest that into this kind of care, into more humans and into more technology, into more things in the platform that help them stay out of trouble, right? That's just not possible in fee-for-service economics, but that's how, like, the work of that coordination is immense. But that's both the privilege and the challenge, right? Of what
You
we
mentioned it. You're really building the innovation is in the bridges that you're building, whether they be internally, the cohesiveness of the clinical and the administrative team, and then the bridges that also extend to patients, that also extend to resources that they wouldn't necessarily know that they actually have access to, and that you're really bridging all those things together. It's a fascinating thing to be able to do it at scale, and it's impressive. And clearly there's a lot more that can be done, and you guys are really knee deep in the work. And you mentioned some of the tech, and maybe we sort of leave with this because we could probably talk about this for a while, but I know we're kind of tight on time here. Is we're about being a community of taking action. For those that are, you know, listening to this conversation, if you had one ask of them and one action point to take, like, what would that be?
It's such a good question. I think that it's really easy in our community as people who are by default attracted to the new and attracted to sort of like, let's go do something really big, right? Or let's do something really transformative, to presume that everyone will share that enthusiasm, right? And or to design for end users like ourselves. And I think one thing I've learned over the years is that like I can't design for some of my friends who are fantastic physicians and like just systems architects like Andrew Schutzbank, who was my boss at Aura, Amidst Desai, who we've worked together for many years here at Oak Street, or Samir Akhtar, who we worked together at Caramore. But you got to be able to build for the everyday human, right? The person who is like still motivated by the purpose and mission of what a place like an Oak Street is trying to do, but has built up scar tissue over the years, maybe has built up some good habits, some bad habits, but the natural developments of a life in the American medical industrial complex. And so recognizing, spending time with those people routinely, not just one off, not just one design sprint, but like helping them to like go through their own trauma informed journey.
Yes.
Right.
Yes.
Engaging them, asking deep questions, recognizing where they may be on a spectrum of change, readiness for change, and then coming back to them consistently, right? But thinking through like that there is just so much heterogeneity across people, across clinicians, across care teams, and then driving that forward, right? To design and to iterate with a lot of empathy.
Yes.
I think it's easy to say and it's hard to do. And that's where I get into that Midwestern engineering of like making sure we do it, right? And that we do it routinely and that we do it with a lot of intentionality. That's the difference. Like I've worked with incredibly brilliant, effective operators and thought leaders and all sorts of folks over the years. But what I've loved at Oak Street is just the foundational anchoring over and over again of like, at the end of the day, how do we take those big ideas and fold them in to the work that it takes to make the trains run on time? And if we can do more of that in healthcare innovation and in primary care delivery and all this work, then that's where the intersection of strategy and operations comes together to actually change people's lives. I think that's really the fun part when we get it right.
Yeah. You know, I wish you could see this video right now because I got goosebumps, because what you described, Dr. Khan, what you described is actually it's actually my theme for the year, and I deduced it down to 2 words. It's called authentic community. And being able to operate and not just go wide, but go deep, go narrow, go focused, and to be in a room where you're not necessarily going to be criticized for showcasing and sharing and being vulnerable about what your issues are. And you mentioned about having a level of tactical empathy. This is what it takes to innovate. So I'm just very, very encouraged that this is something that you're not only talking about, it's something that you're putting into practice. So I'm super excited that there are others that are out there that believe in this, that are doing this and doing it at scale. And I guess it's just fortuitous timing that we got a chance to talk today, and that happens to be my theme for this year. So I guess that means that we'll have to talk more.
I love that, and I can't wait to hear more about it from people who are likely far smarter than me. So, listen, Michael, this has been great. I really appreciate the time.
Looking forward for those that have tuned in, if you found this conversation helpful for you, would you mind just sort of engaging with it, liking it, sharing, and commenting? And we're appreciative of having our community just chipping in and making things move forward. So, Dr. Khan, looking forward to our next conversation. All the best.
Thanks, Michael. Talk soon.